Thank you for having me. I will try and keep it at 15 minutes. I have a lot to go over. As well as I like to put a lot of information out there, so my slides can be a little busy, but I figure it's good for you to have with your information. You can take that home. So I will go ahead and get started. All right, so the learning objectives for today are to review metabolic stress on the body, understand the effects of both hypocaloric and hypercaloric feeding. It's got all funky. Okay, understand how to interpret and implement new nutrition guidelines in recent clinical trials in practice. And then also understanding how optimally managing nutrition needs of the critically ill patient can change the outcome as far as quality of life. So overview of metabolic stress. So during critical stress, the metabolic rate is increased, as you all know. There's complex fuel alterations that occur. So fuel choice is altered from predominantly fat to glucose oxidation. Glycolysis increases enormously, so we're having that rapid breakdown of glucose or glycogen stores. Also, proteolysis and lipolysis are augmented. So when we're eating our foods, that suppresses the breakdown of fat and protein. However, during acute inflammatory stress, this suppression is blunted. All right, so a little bit over hypocaloric feeding. So the body glycogen decreases substantially after 24 hours of fasting. In a healthy individual, this can, over 3 days, will start to induce insulin resistance. Catabolism of lean body mass is promoted, and especially when a patient is bedbound, like pretty much all of our ICU patients, just about. Proteins are used as an alternative source for glucose production. So if you remember gluconeogenesis, back to biochem. So for instance, a 75-kilogram human can lose about 50% of their liver glycogen and 1% of their muscle mass within the first 24 hours after trauma and fasting. And then also, hypocaloric feeding can induce muscle and even heart atrophy in patients that are in long ICU stays. Also, there's an increased risk of morbidity and mortality. I am so sorry, these slides are really kind of messing up here. All right, so patients receiving less than 10 kcals per kilogram of their actual body weight per day have a substantially increased ratio of observed versus expected mortality after day 7. So, in contrast, hypercaloric feeding, which we want to avoid, it increases our carbon dioxide production, and it means that we have to work harder in breathing, which ultimately can mean harder to wean off of the vent. It increases fat storage. The additional energy needed to store in excess of 500 calories may lead to a 33% increase in ventilator workload, and also fatty liver in the presence of that sustained glucose load. There's an increased risk of infection. Autophagia may be hampered. There's fluid overload risk, which is more prominent in parenteral nutrition. And then it is important to note that progressive decrease of the lean body mass over time can increase the risk of overnutrition. So as things are changing in the ICU, we want to have our weight-based calculations reevaluated, because you may now actually be overfeeding. Okay. So I reviewed the following trials and publications. Jillian did a great job talking about the new guidelines. So if you recall, those were derived from studies that were before 2013, the end of 2013. So I'm going to look at the Arabi trial, which was published last year in the summer, as well as a meta-analysis paper by Singer, which all of these studies were included. And then also Dr. Paul Wishmeyer. I got the privilege of seeing him at Clinical Nutrition Week in Austin this year in January. He was a fantastic, vibrant speaker, and I was really touched by a lot of things that he said, so I'm going to use a lot of his information. Okay, so with the PERMIT trial, it evaluated the effective restriction of non-protein calories, and specifically with permissive underfeeding, as compared with standard enteral feeding. The study design was it randomly assigned 894 critically ill adults at 7 different centers, all within Saudi Arabia or Canada. he worked pretty closely with Dr. Hyland, who is very involved with a lot of nutritional studies. It looked at medical, surgical, and trauma ICU patients that were expected to be in the ICU for greater than 3 days. Patients had to be enterally fed within the first 48 hours of ICU admission and could be admitted for up to 14 days. So there were 2 different groups. There was the permissively underfed group, which was meeting about 40 to 60%, of the caloric requirements calculated, or the standard enteral feeding, which was 70 to 100% of the calculated caloric needs. So similar protein was administered for both of these groups. Important to note. So the results were that basically there was no risk in mortality for both groups. And I think a lot of it had to do with the protein. It was the same for both groups. Okay, I'm going to kind of fly through here. So the conclusion of this study was the enteral feeding to deliver a moderate amount of the non-protein calories in the critically ill patient was not associated with lower mortality compared to those with the full feeds. All right, so next on is the opinion paper by Dr. Singer, and this is a chart that looks at all the different studies. It looks at the calorie intervention, so a lot of the times they're either higher or lower in the group compared to the control group, as well as the protein. So I won't belabor all of this, but ultimately I have the conclusion table here. And it's a lot to go over, so since I have a short amount of time, I'll just kind of show you what ended up being. So with the Arabi study, it was okay to underfeed. The Rice study, there was no significant difference. In the Singer trial, it was best to meet near target. In the Kaser trial, it was okay to underfeed. In the Heidegger trial, it was best to meet near target. And then the Doig results was best to meet near feeding. So as you can see, there are mixed reviews all over the place. Consensus is, well, there isn't really a straight consensus. All right, so the summary from this paper, ultimately Singer concluded that enteral nutrition is the preferred route of feeding. The best approach is to target the energy goal defined by indirect calorimetry, which we all, as we saw, do not have access to. It's nice in theory. You want to definitely feed within the first 48 hours. And then also high protein intake is recommended, with this particularly stating at 1.5 grams per kilogram per day. It's recommended, but I'll talk a little bit more about the goals. And it's especially recommended during the acute phase, so really the first 1-2 days of ICU admission. So, and that protein recommendation is regardless of calorie levels. So no matter what calorie you're at, whether you're underfeeding or at goal, you want your protein intake to be met. So the high protein intake really is reducing catabolism. Also supplemental PN should be considered, and a protocol of care is recommended to avoid overfeeding. Oh.
Just close that, Lucy.
Kaiser's trying to get in here. Okay. Okay. All right, so the next information is all from Dr. Paul Wishmeyer. And he talks about different phases of critical illness. There's the acute phase, the chronic phase, and the recovery phase. Okay, I'm so sorry. These slides are driving me nuts. Okay. All right, so during the acute phase, he says that naturally there's a response to the injury, so it induces catabolism. Amino acids and other key substrates are mobilized from various storage sites, as we know. And he's saying that glutamine is signaling the key stress survival proteins in this process. So during the chronic phase, we have energy expenditures increasing. Glutamine is going to be utilized and he's recommending that providing anabolic therapy or anti-catabolic agents during this phase. Also early mobility and physical therapy is recommended, really to use the muscles to prevent further catabolism. During the recovery phase, we have inflammatory markers that are decreasing. So he's saying continue your protein and calories to recover from the lean body mass. deficit, and then anabolic agents and growth hormone may be considered. Of course, continuing physical therapy and exercise. So this is a graphical representation of the stages that he had talked about, and you can see that it should be in your notes there. I won't belabor that. So something that Paul Wischmeyer was talking about was really a lot to do with survival, quality of life after the ICU stay. So he talked about more than 1/2 of all ICU patients worldwide are significantly underfed based on calories and protein, and that they are prescribed within that first 2 weeks, they really are underfed. So there's a huge calorie deficit. Patients receive an average of 50% of the prescribed gold calorie and protein within the first 14 days. So again, a huge deficit, which is not doing any harm or not doing any benefit to our patients. So 40% of the 6-month mortality following severe sepsis occurs after a patient discharges from the ICU. So many of these deaths are believed to occur indirectly as a result of catabolism, loss of lean body mass, a lack of adequate physical activity, and ultimately weakness and inability to mobilize. So I highlighted the lean body mass loss and the catabolism because those are something as dietitians that we can have a direct effect on. All right, and then many patients report very poor physical function related to quality of life scores for a year following ICU discharge. So after ICU discharges, these patients, they're not back to a normal functioning life. And there's a lot of interesting things. I have a link at the end of my slide I want to at least share for you to go home and watch some information on patients' actual testimonials. All right, so based on Dr. Paul Wischmeyer's presentation, this is some of the information that I've learned. ICU mortality has decreased by 50% in the last 10 years. So we're sending a lot of these patients off, and we're cheering ourselves, high-fiving, patting ourselves on the back. We've got them out, but then what? What after? So following that, these patients usually go to rehab. We don't really, there's not a lot of studies that show what happens after. Who's monitoring these patients? What's really the true outcome? So about 40% of these patients actually die 1 year after their ICU treatment. So it's not a long, the rest of their life is very minimized. 50% of these patients go back to work maybe after a year, and about 1/3 of them don't go back at all. So you have to kind of question, what are we doing to these patients if we're really, underfeeding these patients? And it's not all just nutrition. It's just, life is such that, you can't live forever. We can't save them all, and that's okay. But things that we can do to try and prevent those patients that have a higher chance of survival, we want to do the best as clinicians and dietitians to do that. All right, so remember, how you feed your patient in the first week matters for quality of life for months or even years to come. All right, so some of the things, the key topics discussed, you have a decrease of 1 kilogram of lean body mass daily being in the ICU. Your fat mass is gained, which leads to sarcopenia. And a huge discussion at Clinical Nutrition Week was using the ultrasound to measure your quadriceps, to look at lean body mass and actually monitor that. You might have a better understanding. And that's especially true of our obese patients, who they may look like they're fine, and a lot of it has to do with the physical exam that Jill was talking about. But ultimately, deep down in, if you monitor the loss of the lean body mass, you'll see that it's a rapid reduction. And so ultrasound might be a great technique in seeing that process happen. So that's in the future, more to come. We need to get better at providing protein. So this is especially true of our acute renal failure patients. A lot of people are very scared to push the protein and fear that their kidney function is going to be diminished. However, that's not true. Really, you don't want to just restrict protein. That was really numerous across the board. Every single lecture that I went to, it was push at least 1.2 grams per kilogram of protein, no matter what. Okay, and there it is again. So 1.2 to 2 grams is optimal, and it is recommended by the guidelines. So it was shown that less than a gram a kilogram per day had no benefit in the ICU, whereas greater than 1 gram does show a benefit. And for every 30 grams of protein added, it decreases mortality that much more so. So fat mass is, and it increases quality of life. Let's see. So more information. If a patient is not tolerating enteral nutrition, you want to give early parenteral nutrition or supplement parenteral nutrition if they are starting. Feeding post-op day number 1 reduces death mortality by 60%. If a patient is going to be remaining NPO greater than 2 days and is on a ventilator, you want to start TPN. Hyperglycemia is treated with insulin. I know a lot of us worry about the blood sugar control. We have insulin for that. We really need to push the calories and protein if we really want to see, a good change in the patients. There's also the debate about risk of infection. So we have very sterile compounding facilities. Most pharmacies actually are, they have a report of the compounding facility, and they're doing diligent monitoring to make sure that everything is coming back clean. So you can always see that. It was definitely talked about the Nutric risk score. If you're a high nutrition risk, so a score of 5 to 9, you want to start enteral nutrition immediately, unless of course contraindicated. And then using protein supplements and modulars if you need to. So adding that extra protein, if you can't quite meet that protein goal with that enteral nutrition formula, add extra protein. All right, and if your patient can eat, you want to use an oral supplement. So that decreases mortality, complications, it can reduce length of stay, it reduces pressure ulcer formation, and also the cost of care. And a big thing for hospitals, readmission rates. So, a lot of these hospitals are focusing on that because there's a lot of money involved with that as far as reimbursement, getting money from the government. All right, so I'm just going to summarize with the ASPEN guidelines that are kind of pertinent to this information. Overall, in diving into all of this, there isn't really a clear consensus on whether hypocaloric feeding is harmful or helpful. There's a big push to try and get enteral nutrition, at least, or any nutrition started within the first 48 hours of admission to the ICU. Let's see here. And then I know someone earlier was asking about the actual weight-based calculations for the obese patient, so I have them here on the slide as well. And then again, you can always research that. You can find that information if you want to look that up. Okay, so don't forget that nutrition matters. What you're doing is very important to the patient. You're really improving quality of life, after the math, and that's I think that's also, that's part of what we want. We want to make sure that our patients are going to be discharged, going back to a more regular life if we can do that. So there are my references, and then this is the link if you wanted to check out the testimonials of patients with that have been admitted to ICU. And one of them is pretty astounding. It's a patient that was a cancer patient, was on chemo for 2 years, and she had to go to the ICU. She said she'd rather do chemo for 2 years than have a week of stay in the ICU. So it's very interesting to see the actual perception of what these patients are going through. Okay, so I really encourage you all to check that out. Okay, so I know that was hopefully right on time.